In the first part of Chapter 7, we talked about somatosensory testing, different types of conscious and electrodiagnostic studies. Pretty interesting stuff, actually. One of the pathologies that's discussed in the book is shingles, which is caused by the same virus as chickenpox. It's usually itching, burning, or tingling, and eruption of vesicles, and there's often severe pain associated with it. So it's usually, when you get chickenpox, the sensory root cell bodies are infected, and the virus actually remains latent in those cell bodies, in those neurons, until it gets activated later on. It's extremely painful, and usually the vesicles erupt along a dermatomal pattern. So you'll see they're very localized to a single dermatome that nerve root is associated with. So sometimes you can have someone who comes in. I had a lady in the clinic a few years ago. She was referred to physical therapy for low back pain. She went to the doctor referred her to physical therapy. And look, she was really fast about it. So she had the pain, she went to the doctor, she got into therapy in the next few days. Well, the vesicles had not erupted yet, so it wasn't obvious that it was shingles. When the physical therapist evaluated her, she was starting to get a little redness in her low back, and she said, well, I put a hot pack on it, so maybe I left it on too long. So the therapist said, okay, well, that makes sense. By the time she got to see me, the vesicles had erupted. And so I said, uh-oh, this is shingles. I brought another therapist in to verify that what I thought I was seeing was really what I was seeing. I also looked up a picture on the internet to make sure, and we referred her back to her doctor. So physical therapy would have been an inappropriate treatment at that point. What she really needed was the shingles vaccine and probably some pain medication for getting through the acute stage of it. So it's good to know about the presentation of shingles and the type of pain that it causes. It's a peripheral effect, but just kind of interesting. People come in with pain for various reasons, and it's not always obvious right away until things develop. So we talked a little bit about pain last quarter in modalities class. And so just as a definition of pain, we're going to define pain as an unpleasant sensory and emotional experience that is frequently associated with tissue damage or potential tissue damage. Wow, that's important. It means the tissue is not actually damaged, but there's the potential for tissue damage, and we're perceiving that as pain. But pain can also be experienced when there's no tissue damage present. Pain is a perception. Pain results from sensory information and the processing of that information, and the brain decides whether it's going to be pain or not. So there's a nice video in the module called Pain is in the Brain. In the clinic where I work, we do a chronic pain and fibromyalgia education pathway, and part of the information that we use for patient education is called therapeutic neuroscience education. So basically, there is research to support that if you educate people about pain and how pain works in your body, you can actually help decrease people's pain. And there is a physical therapist in Seattle named Adrian Lowe, and for the last few years I've been studying his materials on therapeutic neuroscience education. I just did one of his webinars on pain in children. Very interesting research that he presents on that. One of the objections that therapists will have, they'll say, well, this is complicated information. I can't teach this to my patients if they don't have a prior knowledge of neurology or physiology or anything like that. Well, what Adrian Lowe and research that he presents shows is that you can meet the patient where they are on knowledge, and you can explain it to them. They did some studies with elementary age children and middle school age children educating on pain. And they said children at 5th or 6th grade level are able to understand and process this information. So if a 5th or 6th grader can do it, then anybody can do it. So we can teach our patients about pain, and it actually is a valid therapeutic approach that can help reduce their pain. A really good example of this, a lady that I've been treating the last couple of weeks after her rotator cuff repair. There's a large emotional component to pain. Fear is a strong driver of pain. So she had been in last week. She had the week after Christmas. She had been in. She'd been cleared to do some active and active assisted exercises after her rotator cuff repair, because normally in the maximum protection phase they can only do passive motions. So the therapist added some active exercises. Well, after 6 weeks of not doing active exercises, adding active exercises, she had some increased pain. Well, she was terrified that she had done something wrong and damaged, maybe torn the graft, or the way she put it is she said her shoulder felt like it was out of joint, which it wasn't. But so she came in to me, and she was in a lot of pain because she was afraid. Okay, so I looked at her shoulder. Her shoulder was fine. We did some grade 2 joint mobilizations, very light. We did passive range of motion. And by the end of the session, so 45 minutes, she felt so much better. And when she came in 2 days later, she said, "Oh my gosh, I felt so much better afterwards, a lot less pain." Do you think that the physical treatment that I did for her was the thing that changed the pain, or the explanation that she hadn't done any damage? Largely, my taking away her fear that she had done damage to the tissues had probably had more effect on reducing her pain than the physical treatments I did for her. So education about pain and reassuring the patient can have a bigger effect on reducing pain than the actual physical treatments we do with them. So it's a very powerful, education is powerful therapy. It is something that we can really help our patients with. So another really good example of this is a couple of years ago, my mom had her hip replaced, and she is just about to turn 82 now. So she had it done when she was 80, and she had some sort of preconceived notions. She thought she'd be able to just go straight home from the surgery, and her mobility wasn't all that good to begin with. And so I said, "Are you sure you can go straight home after the surgery, Mom? Because some people do a little time in a skilled nursing facility." Well, she had the idea she was going to go straight home. It turns out she went to a skilled nursing facility, and she was there for a couple weeks, and then I flew out there to Colorado to help prepare her for going home when she was getting ready to get out of the skilled nursing facility. And when I got there, she was in a ton of pain, and she was terrified. And I think part of it had to do with the fact that her mom, when she was in her 90s, had broken her hip, and this was in the 1970s, and they couldn't really do anything for a 90-something-year-old with a broken hip back then. And my grandmother ended up in a nursing home for the rest of the last couple years of her life, and she died there. And I'm sure that unconsciously that was in the back of my mom's mind. She was terrified that she was never going to get out of that nursing home. So her pain level was way higher. She also had a lot of swelling, and that's going to drive her pain level higher too. So when I got there, the first thing I did is I told her about all the plans that we had for bringing her home. and the day that she was going to get out, because we had already planned this. I also did some lymphatic drainage to help reduce her swelling. Well, the next day when I went in, the nurse came up to me and she said, "Oh, are you her daughter?" And I said, "Yeah." And she goes, "What did you do to make your mom's pain so much less?" And I told her about the lymphatic drainage. I didn't say anything about the reassurance part of it. And she said, "You know, when I came in to give her medications last night, I said, 'Okay, do you need your pain medication?' And your mom, for the first time since she's been here, said, 'Nope, I'm not in any pain. I don't need the medication.'" So just that reassurance that she was going to get out and some lymphatic drainage to reduce the swelling made a huge, huge, huge difference in her pain. So pain is perception. Pain is not necessarily caused by tissue damage. Very interesting stuff. So from pain from muscle and joints, both A delta and C fibers transmit pain signals from muscle and joints when tissues are damaged, ischemic, when biochemicals are released that stimulate nociceptors. It makes them excessively reactive to stimuli. They can even fire in response to normally innocuous stimuli. So deep pain occurs in response to tissue damage, and really the biological function of that, it encourages rest for damaged tissues. But we can also get C fibers and A delta fibers to be hypersensitive, excessively reactive to stimuli, and they can fire even in response to normally innocuous stimuli. So there's a little video on nociceptors. This is the sensory homunculus again. The areas of the primary sensory cortex correspond to somatosensory stimulation in individual areas of the body. And as I said in the previous chapter, some areas of the body are disproportionately represented due to increased sensation in those areas. So our hands and our face have more sensation as compared to other areas. We will commonly see a modified gait that's secondary to pain. It's called an antalgic gait pattern. Algia is the Greek word for pain, and ant is anti-pain. It's characterized by shortened stance on the affected side. It's also known as limping. We've all seen it. We've probably all done it at some point in our lives. And then there's a video here demonstrating antalgic gait. So referred pain is pain that appears to come from an area where it didn't originate. So we perceive the pain as coming from a site that's distinct from the actual site of origin. Normally, referred pain is a visceral origin, and it's referred to the skin, the sensory dermatome. The theory of how it happens is that pain fibers from organs and pain fibers from skin converge into collateral branches in the spinal cord, and the dorsal root neuron innervates skin and viscera, and the signal is misinterpreted. So there are some specific patterns, and this is from the book. That's the theory on how it happens, the neurons synapsing on the same dorsal nerve root. But there's common patterns of referred pain. So if you look at like gallbladder pain, number 11, you can see that frequently refers pain to the mid-back and the sort of lower back area. So you don't feel it in the gallbladder, you feel it in the mid-back and lower back. So the pain itself appears to come from an area that's distinct from the actual site of origin. There's a short little video about referred pain. And we're going to wrap up this section in just a couple minutes, and then we will talk about the pain matrix, the idea of the pain matrix. So just as a review, pain is a perception. It's often associated with tissue damage or potential tissue damage or fear of tissue damage, but it can be experienced independently of tissue damage. So nociceptors signal injury, but nociceptor activity in and of itself is insufficient to cause pain. The brain also has to decide that that's what it's going to do. Very interesting. The pain from muscles and joints are signaled by nociceptors. they can be sensitized, causing them to fire in response to normally innocuous stimuli. So frequently after surgery, all the nerves are hypersensitive, and things that wouldn't normally bother you, like your clothes touching you or the blanket touching you, are perceived as pain. Okay? Unlike superficial pain, deep pain usually occurs after tissue damage, and the biological function of deep pain may be to encourage the rest of damaged tissue. So that's why we get that antalgic gait, because our brain goes, oh, I better rest those tissues, I've got some pain going on. That's really the reason for that antalgic gait. So referred pain is pain that's perceived as coming from a site distinct from the actual site of origin, usually referred from visceral tissues to the skin. And the idea is that the convergence and facilitation of nociceptive information from different sources.